students are like majority of the students are in the final year, or they are first year and second year students also?
So now the final year has already passed, sir. So now we
Okay.
have second year going into third year and the first year going into second year.
First year going into second year, and
Yes,
no junior most like first year just entered
no, sir,
first
they
year.
yet to join, sir. They'll be joining,
They're
I
yet to
think,
join.
by end of the year. Yes, sir.
Okay, so that is fine. So I need not discuss about the basic stuff. So
Right, sir.
we shall start with the histopathology of membranous glomerulonephritis, as we are already aware about how you have to make a diagnosis of membranous. There are few newer markers which I am going to discuss, and if you have attended my class, there are some things which will be a repetition kind of a thing. So before I start, okay, so what is there in the terminology membranous glomerulonephritis? Some people call it as membranous glomerulopathy. It is defined by the presence of subepithelial immune deposits that induce a spectrum of changes in the glomerular basement membrane, or GBM. So the terminology, whenever we say GBM, you need to be very clear that GBM terminology is used whenever we comment on ultrastructure examination. Normally, whenever in a kidney biopsy, routine light microscopy, we always say glomerular capillary loop. We never say GBM, glomerular basement membrane. And as you look at the definition, it is defined by presence of subepithelial immune deposits that induce a spectrum of changes in the glomerular basement membrane. So that means this definition is based on ultrastructure examination of a glomerulus. So synonyms for membranous glomerulonephritis includes membranous nephropathy, membranous glomerulopathy, and less commonly epimembranous nephropathy. Why it is called as epimembranous? Because there are subepithelial immune complex deposits which are seen in membranous glomerulonephritis. But membranous glomerulonephritis is the most frequently used terminology. Why it is used like that? Because of the progressive nature of this entity, and there seems to be autoimmune pathogenesis behind it. There are antigen antibody immune complex formation which happens, serum complement fixation, and generation of MACs. So membranous glomerulonephritis is the second most common cause of idiopathic nephrotic syndrome in adults, and FSGS is the first in US and in India. So development of nephrotic syndrome happens over weeks to months. But the problem is whether it is a primary or secondary. That is a major issue when we deal with membranous glomerulonephritis. So when we look at early stage membranous, so early stage membranous will look just like, will have a normal glomerular morphology. So whenever we say that this glomerulus is showing the thickening of the glomerular capillary wall or capillary loop. So here you can see these are the capillary loops with empty lumen, and this is the mesangium. So mesangium is showing only a single nucleus. That means there is no mesangial hypercellularity. So when we label anything as a mesangial hypercellularity, there has to be 4 or more than 4 nuclei in the mesangium. This is the Bowman's capsule. So just see the thickness of the, just compare the thickness of the glomerular capillary wall with the thickness of the tubular basement membrane. If it is very similar, that means it is not significantly thicker. So if you see the thickness of the glomerular capillary wall is more than the tubular basement membrane, then you raise a possibility that most likely I'm dealing with membranous glomerulopathy or membranous glomerulonephritis. So this is a morphological suspicion based on which we say, yes, it looks like membranous. Many times, like early membranous, it will not show any significant thickening of the glomerular capillary wall, and it will look like a normal glomerular morphology. And if you are not doing immunofluorescence, you are going to label this as minimal change disease, because membranous glomerulonephritis in early stage or in stage 1, it will look just like a minimal change disease glomerulus. So they will be absolutely normal morphology. The only unusual finding is you find a dilated or patent or dilated capillary lumen, which can happen even in a MCD. And occasionally what happens is, because there are subepithelial deposits, so on routine light microscopy also, you can see some prominence of podocyte. Normally you don't get to see podocytes so evidently. So if you see, this is a parietal epithelial cell nuclei which is here, okay, and this is a podocyte which is lying just outside the glomerular capillary loop. So if there is lifting of podocyte or if there is prominence of podocyte, that can happen in membranous glomerulonephritis because of the subepithelial deposits. It causes lifting of the podocytes, and the podocytes start appearing slightly more prominent in routine light microscopy. But this per se prominence of podocyte doesn't mean we are dealing with membranous. So you need to do immunofluorescence to demonstrate that there are immune deposits along the glomerular capillary wall. So when I say subepithelial deposit, so this is the GBM. So I use the terminology glomerular basement membrane here because I am looking at ultrastructure examination or I am looking at electron microscope. So here is the GBM. So what you can see here is these dark color things. These are electron dense deposits. And this is the podocyte cytoplasm. Okay. So since they are lying just beneath the podocyte or a visceral epithelial cell, the other name for podocyte is a visceral epithelial cell. This is a podocyte nucleus, a big nucleus, and this is the podocyte cytoplasm. So you can see these deposits 1, 2, 3, 4, 5, similarly 6, 7. So there are subepithelial immune complex deposits. And look at this glomerular capillary, so GBM also, another glomerular capillary loop. You can see deposit here, deposit here, deposit here. So if you see subepithelial immune complex like electron dense deposit, that is consistent with the membranous glomerulonephritis. The other things you see is whether there are deposits in the mesangium. No, there are no deposits. The second thing you see whether these subepithelial deposits or electron dense deposit are seen inside of the glomerular capillary loop also. That means here, which we are not seeing. So these are labeled as subendothelial deposits. Okay. So in this photomicrograph, what you can see is there are presence of these subepithelial deposits. So presence of subepithelial deposits with maybe a thickening of the glomerular capillary wall, and if on silver stain you see this kind of appearance, so fenestrated kind of appearance or sponge-like appearance of the or sieve-like appearance of the glomerular capillary loop in the silver stain. So what is happening is the dark thing is a remnant of the glomerular basement membrane or glomerular capillary loop, and the pale thing which is there, those are the deposits. So it is opposite. You have to remember, normally the glomerular capillary loop or glomerular capillary basement membrane is silver positive. When I say silver positive, that means it is black in color. When you see that there is some paleness in the glomerular capillary wall, that means these are possibly deposit. And this is how, so the pale thing is deposit and the dark thing is the normal glomerular capillary wall. Okay. So when you see this kind of appearance on silver stain, you start suspecting that possibly I'm dealing with a membranous glomerulonephritis or glomerulopathy. Here also you can see this is a podocyte which is quite prominent here. Okay, so you can see this podocyte here. These are the RBCs. This is a hilum. So you can see RBCs in the hilum. You can see RBC within the glomerular capillary loop. And these are the lifted up podocytes which you can appreciate. You can see a lifted up podocyte here. This is a lifted up podocyte. This is the Bowman's capsule. On PS stain, you can appreciate that this is the tubular basement membrane, and just compare this tubular basement membrane with this glomerular capillary basement membrane. So for comparison, you can use this tubular basement membrane. So when I say you compare it with the tubular basement membrane, the tubule with which you are comparing should be a non-atrophic tubules, because atrophic tubules will have a thick tubular basement membrane. So you can see, you can compare this tubular basement membrane with the glomerular capillary loop, and the glomerular capillary wall appears thicker than the tubular basement membrane. So that suggests that we are dealing with, possibly morphologically, we are dealing with a membranous. The other thing is, just see here, I told you that mesangial hypercellularity is when you see 4 or more than 4 nuclei. So what you're seeing here is there is 1, 2, 3, possibly 4 and 5. So 4 to 5 nuclei. Occasionally, you can see some mesangial hypercellularity in case of membranous, but it is said that previously textbooks used to mention that if there is mesangial hypercellularity, if you are finding wire loop like glomerular capillary loops, if you are finding some tubular interstitial changes, it happens more commonly with secondary membranous. But that is not the case. Based on morphology, it is very difficult to say whether we are dealing with primary or secondary. And even a mesangial hypercellularity can be seen in primary idiopathic membranous. So these are in the tubular interstitium. What you can see is many times in cases of membranous, you see these foam cells. So presence of interstitial foam cells is not an unusual finding. Any nephrotic state can produce these kind of interstitial foam cells. So you can see this foam cell, and this is the nucleus, abundant amount of foamy cytoplasm, and at places this is a single foam cell, and at places there could be some small collections of foam cells also in the interstitium. Again, a silver stain which show that some cases of membranous can show segmental sclerosis. So presence of segmental sclerosis doesn't mean that we are dealing with a podocytopathy in addition to membranous, whatever is there. So FSGS lesion, any glomerulus which will uh, progress to global glomerulosclerosis, there will be a stage when there will be a segmental glomerulosclerosis also. So as the disease progresses, you can find in membranous also, and this is commonly seen in advanced membranous, you'll find segmental sclerosis. It is said that those patients who have segmental sclerosis or FSGS lesion uh, in membranous glomerulonephritis, those patients have more massive proteinuria. They can have renal dysfunction also. They have more hypertension, and they progress to end-stage renal disease more rapidly. So this is just to highlight that only advanced membranous will have a FSGS lesion. It is very uncommon for an early membranous to have a FSGS lesion. You have to remember this. And in immunofluorescence, what you will find is you will find very strong IgG. There will be C3, which will not be as strong as IgG. It could be trace. You can just see this. This glomerulus is absolutely negative, and this glomerulus is showing 1+ kind of staining. So C3 is either negative or it will show 1+ or trace to 1+ staining. Kappa and lambda is showing equal staining. That means there is no light chain restriction. This is a classical immunofluorescence pattern of a membranous. I would say a primary membranous, where you find IgG, where you will find C3, which is trace. You'll find kappa lambda, which is equal. So kappa lambda equal means that there is no light chain restriction. A higher magnification, just to highlight, just for comparison again, that sometimes the membrane thickening is so significant, or the membrane, and if it is a very advanced membranous, what you are going to see is, just compare this tubular basement membrane again with this glomerular capillary wall thickness. This glomerular capillary wall thickness is like 2 to 3 times the thickness of the tubular basement membrane. That means it is a very advanced membrane. Similarly, just see here. This looks more like hyalinosis rather than the glomerular capillary wall thickening. So, at advanced stage of membranous will show a significant thickening of the glomerular capillary wall. There could be glomerulosclerosis also. There could be tubular dystocia chronicity also. And in these cases, you will find occasionally that immunofluorescence may turn out to be negative also. So what happens is, ideally, immunofluorescence has to be positive for labeling anything as membranous. So what happens is, if a pathologist looks at this glomerulus at a low magnification, he may like miss these minimal kind of deposits which are seen. So you need to go to a higher magnification to see these minimal kind of deposits. Just compare these deposits with the images which I've shown before, which is like 3+ staining, and these deposits are like 1+ staining. So what happens is, in an advanced membranous, or those membranous patients who are on treatment, who are on immunosuppressive therapy, it is possible that immunofluorescence deposits may reduce in intensity, and you can miss them, or you can label them as something else rather than membranous, because you will say there are no immune deposits for which you are visualizing, but actually you have to go to high magnification to demonstrate these kind of minimal immune deposits which are seen along the glomerular capillary. So whenever I say these are immune complex deposit, that means they will have a granularity. So you can see these dot-like structures. So that means there is some granularity to it. It is not like a linear staining which you see in anti-GPM disease. So you can see these dot-like interrupted granular staining. So presence of interrupted granular staining means that we are dealing with immune complex mediated disease. So when I say interrupted granular, I have shown you ultrastructure examination also of a glomerulus, where the subepithelial deposits are not uniformly placed. They are arranged in an interrupted manner on the GPM. So The advanced membranous. So as I mentioned, stage 3, 4 membranous here. So the advanced membranous is going to show, what you are going to see is just see the thickness of the GPM. The GPM increases in thickness. There will be some dark deposits, and majority of the deposits will be electron lucent. They will not be electron dense. They will be more electron lucent. There will be more thickening of the glomerular basement membrane, more thickening of the GPM, because the deposits from subepithelial location becomes more intramembranous in the advanced stages of membranous. And in stage 3, 4, you will find, in stage 3, you will find some deposits which are electron dense. In stage 4, you are going to see majority of the deposits will be electron lucent. And that is the reason when we do immunofluorescence in these cases, the deposits are very minimal or trace, IgG staining is seen in advanced membranous, because the deposits are no longer electron dense, they become electron lucent. Now the next question is whether we are dealing with primary or secondary membranous. It is very important to distinguish between primary and secondary given the vastly different implications. And since you know that there are n number of conditions which can be associated with membranous glomerulopathy. Okay, and so what happens is, since there are so many conditions which uh, needs to be seen, so the nephrologist will ask the pathologist or the renal pathologist, and he'll ask for clues in the kidney biopsy whether we are seeing any evidence of hepatitis B, hepatitis C, this thing or that thing, lupus, and all that stuff. So it becomes difficult on a routine kidney biopsy to see that because sometimes there will be some tubular interstitial changes. Sometimes there will be mesangial proliferation, mesangial hypercellularity, or endocapillary proliferation. So whenever there is a endocapillary proliferation, there is crescent, there is mesangial hypercellularity. These findings suggest that most likely we are dealing with a secondary kind of membranous rather than primary membranous, because primary membranous should not show any endocapillary hypercellularity or extracapillary proliferation or crescent formation. So distinguishing primary from secondary, historical use of the renal biopsy for clues. So like we used to say mesangial deposits, if they are there, it is likely secondary. Then we used to say if you see IgG subtypings will help. Multiple immunoglobulins on immunofluorescence, that means you are seeing IgG, IgA, IgM. If you see multiple immunoglobulins, it is more consistent with the secondary membranous rather than a primary membranous. But there is extreme paucity of data supporting any of these. Okay. So as you can see here, this is a HND stain, and you can see thickened membranes. And these are the podocytes, which are very prominent. And at places, you see that there is non-uniform thickening. So you can see a thickened membrane like this, then you just compare this membrane with this membrane. So this membrane seems to be twice the thickness of this membrane. So you get a suspicion that whether I'm dealing with lupus, because in lupus or class 5 membranes, you are going to see non-uniform kind of thickening of the glomerular capillary basement membrane or glomerular capillary wall thickness. So if you find a uniformly thickened glomerular capillary wall, it is more consistent with the primary. If you find non-uniform thickening of the membrane, it is more consistent with the secondary. But these are not like foolproof evidence. You need to do immunofluorescence to demonstrate. The other thing is, when you do PS, if you are able to demonstrate that there are occasional capillary loop, just see this membrane and just compare it with this. So non-uniform thickening, when I say, whenever you find these kind of non-uniform thickened membrane, wire loop like deposits, and if on immunofluorescence you find IgG also, little bit IgA, some IgM, and if in IgG, if you find some deposits along the tubular basement membrane, you can see some minimal staining along the tubular basement membrane. So these are the findings which suggest autoimmune pathology. And if C3 is there and C1q is very strong, okay, so all these changes, multiple immunoglobulins, that means IgG, IgA, IgM, C3 and C1q, practically it is a full house immunofluorescence pattern. But I must tell you that in all cases of class 5 lupus or membranous lupus, you are not going to see full house immunofluorescence pattern. Majority of this patient, when I say majority, around 40 to 45% of patient, you are not going to see the full house immunofluorescence pattern. Complements will be normal. sometimes DNA is also negative. Okay, so I remember reporting that time I was not doing PLA2R thrombospondin. So I reported one case in which only IgG was there and C3 was very minimal, a young female. And I reported that as membranous, and we didn't do PLA2R since there was no full house IF pattern, there was no C1q. I labeled that as primary membranous, possibly a primary membranous. This patient after 5 years comes with full blown lupus, okay, full blown SLE and all that. So it is important that we remember this, that full house immunofluorescence pattern will not be seen in all cases of membranous lupus. Kappa lambda is equal, and deposits, when you see here, so there will be deposits which are seen. You can see electron dense deposit along the glomerular basement membrane, along the GPM, and you are seeing these dark deposits also in the mesenteric. So when you see these dark deposits in the mesenteric and along the glomerular basement membrane, it is a hint towards that possibly, yes, we are dealing with a secondary kind of membranous, but immunofluorescence findings and everything you need to keep in mind. But this was a time that, like before 2009, we were concentrating mainly on the whether C1q is there, whether then on morphology we are seeing some crescents, endocapillary proliferation, but then this marker came PLA2. I need not go into the details of this. So you know this, and so serum antibodies against PLA2R is seen in 70 to 75% cases of primary membranous. And in this paper of NEGM, all 8 cases of secondary membranous, they were negative for serum antibodies against PLA2R. So PLA2R can be done by immunofluorescence as well as by immunohistochemistry. So by immunofluorescence, you can see a granular kind of staining. It is just like membranous. It's just like IgG staining when you look at in a case of membranous. And if it is PLA2R negative, it will show absolutely negative staining. There will be no staining at all. So PLA2R can be done by immunofluorescence or by immunohistochemistry. I do by immunohistochemistry methodology, and it is as good as immunofluorescence. So PLA2R in membranous, it has got diagnostic utility, which you all know, if present, can be used to monitor treatment and progression. So serum test is available that you know. Now we come to like when I report any case of membranous on morphology, it looks like okay, membrane thickening is there. Immunofluorescence pattern is like primary membranous. Then what next? So we can do IgG subclasses, and I have found that doing IgG subclasses, if you do it with PLA2 or thrombospondin, it is very useful, and you will be able to categorize at least 80% cases of membranous. So if you find a dominant IgG4 subclass staining, minimal kind of IgG1, it goes more in favor of a primary membranous. I know looking at the IgG subclass pattern of staining, that whether this patient is going to turn into a, whether this patient will show a positive PLA2R or negative PLA2R. Okay. So this was a 35-year female with nephrotic syndrome. IgG was, so there was membrane thickening, which was there, uniform membrane thickening was there, lifting up of podocytes. IgG was granular, so you can see the granularity here. You can see these kind of granular deposit. So it was granular along the capillary loop. Occasionally, when you look at the immunofluorescence, because it is a 3-dimensional loop, what you are seeing. So at places you'll find that it will appear that in the mesenteric also some staining is there. So the best localization of deposits, whether the deposits are there in the mesenteric or along the glomerular capillary loop, that can be best done. The best localization of deposit can be done only ultrastructurally, only on electron microscopic examination. So there was IgG, there was no IgA, IgM, CD3 was negative, C1q was trace. So this creates problems because everything fits with the primary membranous. On morphology, there is no endocapillary proliferation, there are no crescents, and I'm seeing the IF pattern, which is classical of primary membranous, where there is IgG, there is C3, which is negative or trace, but there is some minimal C1q. It is not. It is, but the C1q is not like 3+. So now I'm confused whether I'm dealing with primary or secondary. I do IgG subclasses. If on IgG subclass I find 1 plus IgG1 or maybe negative IgG1, 2, 3 is negative, and 4 is like 3 plus. So if I find dominant IgG4 subclass staining, I'm sure that I'm dealing with a primary membranous. So next step I'll do is I will do PLA2R staining. If PLA2R is positive, that it is confirmed that it is a primary membranous glomerulonephritis. So similarly, you can also do thrombospondin in these cases. So in my experience, like majority of the times, like if I report 100 biopsies, so around 75 to 80% biopsies will be PLA2R positive. Thrombospondin positivity is very unusual in our practice, but this is my observation in the last 2 years. I've seen suddenly there is like coexistence of or dual positivity for PLA2R thrombospondin cases. Whether it is related to COVID or something else, I'm not sure, because yes, majority of these patients had history of COVID or COVID antibodies were positive. Whether that is a reason that is causing some these cryptic antigens getting exposed or something of that sort. But yes, it is not a common thing to find thrombospondin associated membranous. It is not a common type of primary membranous. So the most common type is PLA2R, and 70 to 80% times it is PLA2R only. And if the world literature says that 70 to 75% is PLA2R, and maybe 1 to 8, around 5 to 7% or 5 to 8% is thrombospondin associated. So if you do PLA2 and thrombospondin with IgG subclasses, we will be able to cover at least 80%, 80 to 85% of primary membranous. Now remaining are 15 to 20% cases. So we come to another case, 17-year female with nephrotic syndrome, 24-hour urine protein was 6.4 gram, urine RBC is 1 to 2, serum creatinine was 0.5. So on morphology, you are seeing the glomerular capillary wall thickening is there. Occasional wire loop-like deposit is there. IgG shows granular staining, and also extraglomerular staining is seen along the tubular basement. So if you see extraglomerular staining, it suggests that most likely we are dealing with a autoimmune kind of disorder. C3 was there, C1q was strong. So everything fits. Even the morphology suggests was raising a possibility that possibly I am dealing with a secondary membranous. And on immunofluorescence, on immunofluorescence, there was strong C1q. And on ultrastructure examination, you can see these deposits which are there. Occasionally, this is also glomerular basement membrane only. It is not a mesangial deposits. But yes, and not in all cases of class 5 lupus, you are going to see mesangial deposit. The other thing in ultrastructure examination is you look for mesangial deposits, you look for subendothelial deposit, and you also look for tubular reticular inclusions in the endothelial cells. These are the three things which we need to be careful about. Tubular reticular inclusion per se, like it is not like if tubular reticular inclusion is there, it is likely a lupus. So tubular reticular inclusions are commonly seen in lupus nephritis, but they can also be seen in some viral infections, HIV positive patients, those patients on certain type of interferon therapies. So it can be seen in viral infections, autoimmune diseases, and on patients on certain interferon therapies. It is not very specific for lupus. And if I do IgG subclass in case of a class 5 lupus nephritis, I will find IgG1, IgG2, which will be like 3 plus, IgG3, which is like trace, but IgG4 will be negative. So either there are multiple IgG subclasses which are there. It will not be like IgG4 is 3 plus and rest of the subclasses are like 1 plus or negative. The likely scenario will be there will be multiple IgG subclasses, but the dominant subclass will be IgG1 and 2, and IgG4 will be negative in majority of the cases. So if you find negative IgG4, negative PLA2 or thrombospondin, this kind of a morphology, you are sure that we are dealing with a secondary membranous. So it is a class 5 lupus nephritis. Another case, 60-year male with nephrotic syndrome, C3 normal, C4 normal, mild renal dysfunction, serum creatinine was 1.7. So looking at this glomerulus, what do you think? So I need to be asking questions also. So participants, tell me, how does this glomerulus looks different from a routine kind of primary idiopathic membranous glomerulonephritis? Can anybody tell me? Yes. You can write comments in the, okay, Dr. Santosh Kumar said mesangial cellularity. Okay. Anything else? Anything else other than mesangial cellularity? Mesangial matrix. Okay. So I'll tell you, when we say there is lipid reabsorption droplets, okay. Anything else? Please, please. Whitening of the glomerular space. Okay, good, good. Whitening of the urinary space. There is some minimal whitening of the urinary space. Very good. What else? So there is thickening of the glomerular capillary wall for sure. There is minimal kind of mesangial expansion, but there is no mesangial hypercellularity, because when I say mesangial hypercellularity, there has to be more than four or more than four nuclei. So here you can see one nucleus. You don't see any significant mesangial hypercellularity. The other thing is, you can see these things inside the glomerular capillary loop. Look at this. What are these? Yes, in the chat box. What are these? What are these cells? So what is this labeled as? Inside the glomerular capillary loop, if you find certain cells which are inflammatory cells, if I say these are lymphocytes and possibly occasional neutrophil also. So if these are lymphocytes inside the glomerular capillary loop, what we label this as? We label this as endocapillary hypercellularity. Okay, so there is endocapillary hypercellularity. There are so presence of endocapillary hypercellularity means we are dealing with morphologically. It suggests that we are dealing with possibly a secondary kind of membranous, because primary membranous should not show any endocapillary hypercellularity. We did immunofluorescence. Immunofluorescence show IgG, which is a IgA negative, C3, which is like trace. Kappa is like 2 plus, and lambda was less or possibly negative. So this is just comparison for kappa and lambda. So kappa is there, but lambda is negative. So this is unusual, because if you see there is light chain restriction, then you have to think whether I'm dealing with a dysproteinemic state or something of that sort. Any criteria for the diagnosis of endocapillary hypercellularity? No. See, the thing is, it is said that endocapillary hypercellularity, whenever there is this question in the chat box, that endocapillary hypercellularity, it is said that if you find endocapillary inflammatory cells, okay, sometimes it becomes very difficult to say whether this is a plump endothelial cell or whether it is a inflammatory cell which is there, because lymphocyte is round, even a plump endothelial cell will appear round. So it is said that if the endothelium reacts to whatever is there in the capillary loop, that means if there are inflammatory cells, but the endothelium is also reactive, then it is endocapillary hypercellularity. If you find occasional lymphocyte here and there, then you can ignore it, because that could be in the circulation also. This is that lymphocyte has come. So if you find endocapillary hypercellularity, means the capillary lumen is full of inflammatory cells, or if even if the cells are less, but the endothelial lining is reacting to that inflammatory cell, then you consider that as endocapillary hypercellularity. There is no number. There is no number like it has to be 2 cell or 3 cell or 4 cell. It is just that the whatever cell is there, it should be reacting to the endothelial lining. Okay, so kappa is like positive, lambda is negative. We did IgG subclasses and it shows IgG3 staining. IgG1, 2, and 4 is negative. So it is a very common scenario whenever you must have seen reports where there is evidence of where the diagnosis of MGRS is given. And in those cases, if IgG subclasses are performed, you will see that it is dominantly IgG3 subclass which is seen. So presence of IgG3 subclass, can anybody tell me why only IgG3 subclass is deposited in cases of MGRS? In the chat box, you'll see 90% of the times, or I would say 95% of the cases, you are going to see there will be IgG3, which will get deposited. So IgG3 has got the highest molecular weight and it is more complement fixing antibody. Okay, it leads to more complement activation and all that. So that is why highest molecular weight is the most important reason. That is why it gets deposited, and that is the most common IgG subclass which gets deposited in cases of MGRS. So in this case also on kappa lambda we can label this as MGN Vitis proteinemia because there is light chain restriction. But if you do IgG subclasses also in these cases, you are very sure, because in a MGRS case or in a MGN Vitis proteinemia, you are going to find only one subclass. It is not going to happen that you are going to see IgG1 and IgG3. There will be only one subclass which will be positive. So this is a IgG3 kappa restricted membranous. And there are more newer markers which have come in the last few years. So one is exostotin 1/exostotin 2 associated membranous nephropathy. This was an article by Dr. Sanjeev Sethi. And I remember using these exostotin 1 and 2 antibodies. They are very difficult to perform because it gives a lot of background staining. I just want to highlight you. These are the cases which are negative, and these are the cases. This is from the same article where they have said that there is a granular staining along the capillary loop. You can see this brown color. Okay. Now the problem is there is little brown color which is there in the background also. You can see some tubules which are staining with this, uh, antibody. So what happens is if the background is not clear or if the background staining is there, it becomes very difficult to interpret these stains. So the background has to be clean. As compared to PLA2 or thrombospondin, PLA2 and thrombospondin will not give any background staining. And on based on this article, he suggested that exostotin 1 and exostotin 2. So these are parts of so the glomerular basement membrane is composed of collagen type 4, it is composed of laminin, and it is composed of heparin sulfate and one or two more proteoglycans. So heparin sulfate, exostotin 1 and 2 proteins, they are associated with forming framework, or they are involved in heparin sulfate formation. So it is suggested that if there is exostotin 1 and 2 staining in the glomerular capillary loop, it is more likely a membranous associated with autoimmune disease. Okay. So in his paper, he suggested that a subset of membranous is associated with accumulation of exostotin 1 and 2 in the GPM. So autoimmune disease is the most common in this group of patients. So what happens is, if we are doing IgG subclasses and if we are doing immunofluorescence, that is there. But as I've told you, if we do IgG subclasses, that will give a decent clue towards whether we are dealing with secondary. But the role of this marker exostotin 1 and 2 is that it will suggest that whether that secondary cause is an autoimmune cause or not. The other important thing is what he highlighted in this paper is there is a lot of brown staining in these, but there is very minimal kind of brown staining in this case. So what he suggested was, if you find exostotin 1 and 2 staining, strong staining, it is commonly seen with a non-proliferative lupus, and that too in membranous lupus. It will not be seen in a class 2 lupus. It will not be seen in any proliferative lupus. So if there is a class 5 plus proliferative, focal proliferative lupus, that means there is a membrane thickening. It is classical class 5. There are few glomula which are showing crescents. So he suggested that those cases with little bit of proliferative component also, they will not show a significant exostotin 1 and 2 staining. So the role of exostotin 1 and 2 is mainly in membranous glomerulonephritis secondary to autoimmune diseases, not in any proliferative kind of glomerulonephritis due to autoimmune disease or any proliferative lupus. And now this is the most recent marker which has come in. I'm not aware if there are any further markers which have come after this. Neural epidermal growth factor 1 protein NEL1 associated membranous. So this is a better marker, I would say, than exostotin 1 and 2. Reason being, Dr. Sethi suggested that NEL1 is seen in around 15 to 16% cases of primary idiopathic membranous. So that means if you are doing PLA2 or thrombospondin, PLA2R is like 70 to 75%. If there is if you're doing NEL1 also, that means you are covering around. He said that NEL1 is the second most common antigen after PLA2R, and that is possibly correct also because uh, thrombospondin is not common. Thrombospondin out of maybe 500 biopsies, you see, and okay, 500 cases of membranous, you see only one or two cases of thrombospondin positive membranous. So practically, majority of these patients are uh, negative for thrombospondin. So PLA2R positivity is the most common, and after that in my experience, I've seen that membranous in young adults, they are mostly PLA2R negative, and in that IgG1 subclass is the most common subclass which we see. He suggested for NEL1 that NEL1 is commonly seen in those membranous which show IgG1 subclass dominance. IgG4 subclass dominance is not seen in NEL1 associated membranous. In his cohort of patients, there were few patients who had associated malignancy also, but then he suggested that uh, his complete cohort of patients, there were very few such patients who had cancer. So he doesn't want to relate that NEL1 is associated with malignancy, but he suggested that this is a small sample size. We need to study it further. Okay, but yes, overall 34 NEL1 positive cases, 16% were identified in 210 PLA2R negative biopsies with all cohorts combined, and that is more than double the number of thrombospondin cases in the original study. So practically, he's saying that it is the second most common antigen after PLA2R in membranous. So taken together, the findings suggest that NEL1 is the second most common antigen after PLA2R in primary membranous. Further studies are needed to understand the prevalence discrepancy of NEL1 positive membranous. In conclusion, he said that we have identified a novel protein NEL1 in subset of PLA2R negative membranous in adult patients, and NEL1 associated membranous appears to be a distinct type of primary membranous. Okay, so this was my last slide, and if you have any queries or any questions, so I can answer them. So you need to remember that if we are doing uh, complete immunofluorescence, so there are still some centers who are not doing kappa lambda, who don't do kappa lambda immunofluorescence, and they say that kappa lambda will be done only if there is an elderly patient or that. So ideally, you should be doing complete immunofluorescence, all the antibodies related to in immunofluorescence panel. You should have all the immunoglobulins and complement. That means IgG, IgA, IgM, and complement C3, C1q, along with light chains. Okay, and IgG subclasses, PLA2R thrombospondin if you are doing. So that means if, how to measure GPM thickness. So that can be measured. It's compared with the tubule wall thickness. Yes. So the terminology when I say GPM, that means we are talking about ultrastructure examination. So Dr. Singla, he asked that how to measure the GPM thickness. It is measured ultrastructurally on electron microscopic examination. It is not measured on routine light microscopy. Then Dr. Biswas asked, it's compared with the tubular wall thickness. Yes, it is on light microscopy. It is very simple kind of thing that it is said that if you compare it with the tubular wall, non-atrophic tubular basement membrane, uh, it is a rough sign that whether anybody, when we label anything as a glomerular basement membrane thickness, we just compare it with the tubular basement membrane, non-atrophic. But yes, the ideal is get the GPM thickness done, which can be done on ultrastructure examination. But the GPM thickness, if there is no cutoff for GPM thickness. If GPM thickness is like this, then it is membranous. If GPM thickness is this, if GPM thickness utility is mainly when we deal with thin basement membrane disease. And that diagnosis, as we know, that it is made only on ultrastructure examination. Yeah. Any further questions? Can IgM be positive in primary? So the thing is, I told you the most common thing what you see is patient had PLA2 positive in biopsy, sir, but IgM was also positive in a case with IgG4 and IgG3. So IgM was also positive. So the thing is, IgG will be positive. Along with that, there could be a little bit of IgM. That is fine, but mostly in majority of the patients, IgM is not commonly seen in uh, uh, in a primary membranous. It will be very unusual. It is a occasional rare case may be there, but it is not a common finding to see IgM. No secondary cause was found. That's why. Okay. And presence of IgG3 and IgG4 is also unusual. The commonest combination what I see in primary idiopathic membranous is IgG1 and IgG4. It is never IgG3 and IgG4. So that also is unusual. Yes, I understand when you say that no secondary cause was found, because I must tell you that we there are some cases which we are still missing. If it comes PLA2 up, so this case what I want to ask is whether PLA2 was positive. Yes, he said that patient had PLA2 positive on biopsy, but IgM was also positive in a case with IgG4, IgG3. So I must tell you that there are some cases of membranous which are associated with IgG4 disease. So in those cases, interstitial pathology, there will be rising serum creatinine, and these patients will have an increased number of plasma cells in the interstitium, and along with that there will be membranous. But if you find PLA2 a positive in this case, you don't label this as IgG4. You label this as PLA2R associated MGM. Yeah. Any more questions? Is primary Dr. Biswas? Okay. Okay, is it possible to have PLA2R negative and IgG3 predominance? Yes. If you see IgG3 predominance, so when you say IgG3 predominance, either you say only IgG3 is there. So it is only IgG3 channel. If there is PLA2R thrombospondin which is negative, and I see IgG3 only, I must tell you, I will look carefully at kappa lambda, because mostly IgG3 dominant diseases or IgG3 only staining is seen with MGN with dysproteinemia. So if you see cases of proliferative GN with monoclonal immunoglobulin or PGN-MID, IgG3 is the most common immunoglobulin which is positive. So if you see IgG3 predominance or only IgG3 staining, I would consider if it is elderly patient and all that. So I must say age is also not a criteria. I've seen 35-year-old male with MGN with dysproteinemia. But what happens is these patients, when you get the electrophoresis done, serum free light chain assays done, there is no abnormality. It is only on follow-up. That means maybe 10 years follow-up, you'll come to know whether these patients developed some MGUS or developed some lymphomas or any kind of monoclonal diseases. So any more questions? So if there are no further questions, so Puneet,
Yes, sir.
so all done?
Yes, sir. Thank you so much, sir.
Okay,
Yours is
thank
always
you.
a master class. Thank you so much.
Thank you. Thanks a lot.
Thank you, sir.
Thank
Thank
you.
you, sir.